This is recorded lecture for Chapter 26, the Reproductive System. Excuse me. That would be the last chapter of the Anatomy and Physiology 230 course. The reproductive system includes the primary sex organs, which includes the gonads. That would be the testes and the ovaries. Put this there. They produce the sex cells, the gametes. They secrete the steroid sex hormones that would be androgens in males and estrogens and progesterones in females. And they are also, we have accessory reproductive organs, which are the ducts, the glands, and external genitalia. So basically what this is saying is that the primary sex organs are really only the testes and the ovaries. Everything else is sort of extra. If you have those, then you can actually create conception. The sex hormones play roles in development and function of the reproductive organs. Sexual behavior drives, and the growth and development of many of the other organs and tissues, and that's kind of important to know that. The testes within the scrotum actually do several things. They produce sperm. The sperm are delivered to the exterior through a system of ducts, that being the epididymis, the ductus deferens or the vas deferens, the ejaculatory duct, and finally the urethra, and we'll take a look at that in a bit. The accessory sex organs, the seminal vesicles, the prostate and bulbal urethral glands, empty secretions in the duct during ejaculation and help make up part of the ejaculate. What we're seeing here is you'll see the testes, which are located on the outside, because sperm do not do well at body temperature. They don't last a long time, and so the scrotum holds the testes outside of the body, the core body, if you will, the abdominal pelvic cavity, which allows them to be allows the sperm to be held at a lower temperature. You can see the testes proper. There is the epididymis. You can see the gland, the vas deferens or the ductus deferens. You'll see that as it becomes the seminal vesicle. You'll see the ejaculatory duct as it goes through the prostate proper, and finally it'll become the urethra as it exits the body. The scrotum is a sac of skin and superficial fascia. It hangs outside the abdominal pelvic cavity, and it contains a pair of testes, and the temperature is about 3 degrees centigrade lower than the core body temperature, because that temperature, as I said before, is necessary for sperm production. The temperature is kept constant by 2 sets of muscles: the smooth muscle that wrinkles the scrotal sac, called the dartos muscle, and bands of skeletal muscle that elevate the testes, called the cremaster muscles. You see the urinary bladder located there. There's the urethra. There's the cremaster muscle right here, and then you see the dartos muscle of the scrotum proper. The testes each are surrounded by 2 tunics. There's the tunica vaginalis and the tunica albuginea. The tunica vaginalis is derived from peritoneum, and the tunica albuginea is the fibrous capsule. The septa divides the testes into 250 to 300 smaller lobules, and each of the lobules contains 1 to 4 seminiferous tubules, which is the site of actual sperm production. The sperm are conveyed through seminiferous tubules, tubulus rectus, redi testis, the efferent ductules, and finally the epididymis, in that order. The blood supply comes from the testicular arteries and the testicular veins, and the spermatic cord encloses the nerve fibers, the blood vessels, and the lymphatics that supply the testes proper. This shows you that process. You can see the spermatic cord as it comes down. The blood vessels come down and feed the blood vessels, arteries, and veins that feed. Excuse me. That feed that testes, and you get a feel for the tracks of the fluid or the sperm production proper. You see the seminiferous tubules, and finally we get to the redi testes proper. You can see as it enters the epididymis, as we get to the epididymis, and finally as we enter the vas deferens. The testes, the interstitial lining cells outside the seminiferous tubules, actually produce the androgens. In this case, would be testosterone. And there's the seminiferous tubules, the interstitial cells, the spermatic cells, the tubule epithelium, and you get a nice feel for what we're talking about. And there you can see the sperm as they're being developed. The penis is external genitalia, the external genitalia are the scrotum and the penis. The penis is the male copulatory organ, obviously, and the penis consists of the root and shaft that ends in the glans penis. The prepuce or the foreskin is the cuff of loose skin that covers the glans, and when their circumcision occurs, that's what they remove, is that foreskin. The crura is the proximal end surrounded by the ischio-cavernous muscle, which anchors the penis to the pubic arch. The spongy urethra and three cylindrical bodies of the rectal tissue, spongy network of connective tissue and smooth muscle with vascular spaces, include the corpus spongiosum, which surrounds the urethra and expands to form the glands of the bulb, and then the corpus cavernosum, which are a pair of dorsal caverns, dorsal erectile bodies, which help to create erection, if you will. And so that erectile tissue fills with blood, causing the penis to enlarge and ultimately to become rigid. You get a feel for what we're talking about. What you're seeing here is the corpus cavernosa on each side, and finding that this corpus spongiosum, which actually surrounds the urethra proper, and that gives you a feel for the body of the shaft of the penis proper. The male duct system includes the epididymis, the ductus deferens, the ejaculatory duct of the urethra. We said that before. The head contains the efferent duct. The duct of the epididymis has microvilli or stereocilia, which absorb testicular fluid and pass nutrients to the stored sperm. The non-mole sperm pass slowly through and become motile. During ejaculation, the epididymis contracts, expelling sperm into the ductus deferens. The ductus deferens passes through the inguinal canal, which is the opening into the abdominal cavity. It expands to form the ampulla and joins the duct of the seminal vesicle to form the ejaculatory duct within the prostate proper. Propels sperm from the epididymis to the urethra. A vasectomy is the cutting and ligating of the ductus deferens, which is nearly 100% effective form of birth control. As we said, the urethra conveys both urine and semen at different times. It has three regions. It has the prostatic urethra, the membranous urethra, and the spongy or the penile urethra. And we just already talked about that as we went through, as we went down to the urethra before. The cystary glands are the seminal vesicles. They produce a viscous alkaline seminal fluid. It's rich in fructose, which is a sugar which gives the sperm energy, has ascorbic acid and coagulating enzymes, vesiclase, and prostaglandins. And 70%, it represents 70% of the volume of semen. The duct of the seminal vesicle joins the ductus deferens to form ultimately the ejaculatory duct. The prostate encircles part of the urethra inferiorly to the bladder, and it secretes a milky, slightly acid fluid which contains citrate, enzymes, and prostatic-specific antigen, PSA. PSA is really what's measured when you're looking for cancer, because the PSA antigens, will start to go up. It plays a role in activation of sperm and enters the prostatic urethra during ejaculation. And finally, we have Cowper's glands. Cowper's glands, which are pea-sized glands, which are just inferior to the prostate. They're sometimes called the bulbourethral glands. Prior to ejaculation, they produce a thick, clear mucus which lubricates that gland's penis and neutralizes traces of that acetic urine that might be retained in the urethra, and that lets you see that also. Semen is a mixture of sperm and accessory gland secretions. It contains that nutrients, that fructose we talked about, which protect and activates the sperm and facilitates their movement via relaxin. Prostaglandins in semen decreases the viscosity of mucus in the cervix and stimulates reverse peristalsis in the uterus. The alkalinity neutralizes the acid in the male urethra and the female vagina, and antibody chemicals actually destroy certain bacteria. So clotting factors coagulate semen just after ejaculation, then fibrinolysis liquefies it. Only 2 to 5 mils of semen are ejaculated, containing about 20 to 150 mils of sperm, depending on age and all sorts of things. An erection is the enlargement and stiffening of the penis, which actually engorges the erectile tissues with blood. It's initiated by sexual stimuli, which can include touch and mechanical stimulation of the penis, but also through non-tactile elements like sights, sounds, and smells. And it can be induced or inhibited by emotions of higher mental activity. The parasympathetic reflex promotes the release of nitric oxide. Nitric oxide causes erectile tissue to fill with blood. There is expansion of the corpus cavernosa, and there's compresses the drainage veins and maintains engorgement. So the corpus spongiosum keeps the urethra open, and impotence is when the ability to attain erection. Ejaculation is the propulsion of semen from the male duct system. The sympathetic spinal reflex causes the ducts and accessory glands to contract and empty their contents. The bladder sphincter muscle, the bladder sphincter muscle causes it to constrict and prevent an expulsion of urine, and the bulbospongiosus muscles to undergo a rapid series of contractions to help move the sperm. Spermatogenesis is a sequence of events that produces sperm in the seminiferous tubules of the testes, and most body cells are diploid. That means they contain 2 sets of chromosomes, one maternal and one paternal, and they have 23 pairs of homologous chromosomes. Gametes are haploid, if you will, and they only contain 23 chromosomes. So instead of 46, they contain only 23. The gamete formation involves meiosis. There's a nuclear division of the gonads in which the number of chromosomes is halved from that 46 to 23. 2 consecutive cell divisions, which are meiosis 1 and 2, are following one round of DNA replication produces 4 daughter cells, which introduces that genetic variation because each of those daughter cells can be a little different. So this takes you through the process. So here's what's really interesting. You go through the prophase, there's the meiosis, you go through prophase, there's duplication. There's metaphase 1, where there's tetrads are aligned randomly to spindle equator in preparation of anaphase. There's anaphase 1, where you go through that process. And finally, what happens ultimately through telophase is half of the chromosomes go one way and half go the other. And this takes you through that process again. There's prophase, if you will, and the meiosis 2 begins the products of meiosis 1, the 2 haploid daughter cells, and they undergo a mitosis-like nuclear division process referred to as equational division of meiosis. So they go through that process to divide and become 2 daughter cells, ultimately each one. So you can see that there's a difference in the genetic material in each one of those potential daughter cells. The mother cell before the reproduction, if you will, there's mitosis, which is the prophase. You see that. You get the daughter cells of mitosis. Through meiosis, you can see that there's a separation because what happens is there's no process. What you get in the daughter cells is exactly the same as what's in the mother cell. When you get into meiosis, what happens is there's a splitting of the chromosomes, and so you get 2 daughter cells that are not the same. They're actually very different, and then they go through a process, almost a mitosis-like process, to develop those 4 daughter cells. Very different process, and this talks about those differences we just went through. Spermatogenesis, spermatic cells give rise to sperm. There's a mitosis, which spermatogonia forms spermatocytes, a meiosis where the spermatocytes form spermatotids, and spermatogenesis where the spermatotids ultimately become sperm. This is a scanning electron microscopy, a cross-section view of a seminiferous tubule. And then you see what you're seeing here is you're seeing that process where ultimately you end up with sperm cells. Mitosis of spermatogonia begins at puberty. Spermatogonia are stem cells come in contact with epithelial basal lamina. In each mitotic division, a type A daughter cell and a type B daughter cell are produced. Type A cells maintain the germ cell line at the basal lamina, and type B cells move towards the lumen and develop into primary spermatocytes. So in meiosis 1, the primary spermatocytes go from a 46 chromosome cell, and they're broken down into 2 23 chromosome cells. In meiosis 2, each secondary spermatocyte, that is the 23 chromosome cells, then breaks down into 2 other cells, each one, what are called spermatotids. Spermatotids are small non-motile cells which are close to the lumen of the tubule. And you see that's what happens. You see the spermatotids, early spermatotids. Late spermatotids start to develop. They still have that sort of a wing-like structure, and you can see the tails beginning to form. And finally, they develop into spermatozoa. Spermatogenesis, spermatotids to sperm. The spermatotids lose that excess cytoplasm and form a tail, becoming the spermatozoa we just saw. The major regions of the sperm are the head, which is the genetic region. It has a nucleus and a helmet-like acrosome, which contains the hydraulic enzymes that enable the sperm to penetrate an egg. There's the mid-piece, which is the metabolic region, and contains the mitochondria, and the tail, which is really just the flagellum, which is the locomotion area. This takes you to the process of the growth of the sperm as they mature. The role of the cystodicular cells, or large supporting cells, are also called Sertoli cells. They extend to the wall of the tubule and surround the developing cells, and they provide nutrients and signals to dividing cells. They dispose of excess cytoplasm sloughed off during spermatogenesis, and they secrete testicular fluid and lumen for the transport of the sperm. The tight junctions divide the wall into two compartments of the cystodicular cells, the basal compartment, which is spermatogonia and the primary spermatocytes, and the adluminal compartment, which is meiotically active cells, and the tubule lumen, that's where they live. Again, same chart we've seen before. The role of the cystodicular cells, the tight junction, form a blood-testis barrier which prevents sperm antigens from escaping the blood where they would activate the immune system. Not good. Because sperm are not formed until puberty, they are absent during the immune system development, and they would be not recognized as self, so the body would start to destroy them. Hormonal regulation of male reproductive function is a sequence of hormonal regulatory events which involve the hypothalamus, the anterior pituitary gland, and the testes. That's called the hypothalamic pituitary gonadal axis, or HPG axis. The hypothalamus releases a gonadotropin-releasing hormone, or GnRH. GnRH stimulates the anterior pituitary to secrete the FSH and LH. These are things we talked about already within the endocrine system. FSH causes the cystodicular cells to release androgen-binding protein, ABG, which makes spermogenic cell, which is receptive to testosterone, and so that helps develop the sperm. The LH stimulates interstitial cells to release testosterone. So LH is responsible for testosterone, FSH is responsible for developing the sperm. Testosterone is the final trigger for spermatogenesis, and the feedback inhibition of hypothalamus and pituitary results from rising levels of testosterone, and inhibin, which is released when the sperm count is really high. This takes you to that whole process, and I would look at this chart. It's really helpful. The mechanisms and effects of testosterone activity. Testosterone is synthesized from cholesterol. It's transformed to exert its effect on sub-target cells. Dihydrotestosterone, DHT, in the prostate, and estrogen in some neurons in the brain. It prompts spermatogenesis, and it targets all the accessory organs, and deficiency leads to atrophy. It has multiple anabolic effects throughout the body. Anabolic, remember, is the buildup of complex molecules. It's the basis of sex drive, the libido in males. It features induced in non-reproductive organs by the male sex hormones is mainly testosterone. So most of the non-reproductive organs of the features that are induced by testosterone in the non-reproductive organs include the appearance of pubic axillary facial hair, the enhanced growth of the chest and deepening of the voice, the thickening of the skin, and it becomes more oily, the bones grow and increase in mass and density, and skeletal muscles increase in size and density. So it has some secondary effects also. We talk about female reproductive anatomy. The ovaries are the female gonads. They produce the female gametes, the ova. They secrete the female sex hormones, which are estrogen and progesterone. They have accessory ducts, which include the uterine tubes, the uterus, the vagina. The internal genitalia include the ovaries, the uterine tubes, the uterus, and the vagina. And the external genitalia include the external sex organs. This goes through that process. You can see this in the chart. You can see there's the ovaries proper, the fallopian tubes that comes down and enters into the uterus. You see the uterus as it opens the cervix. the vaginal vault as it opens into the introitus of the vaginal opening. The ovaries are held in place by several ligaments, but they're free-floating within the abdomen. So the ovarian ligament anchors the ovary medially to the uterus. The suspensory ligament anchors the ovary laterally to the pelvic wall, and the meso-ovarium suspends the ovary. There's also a broad ligament which supports the uterine tubes, that being the fallopian tubes, the uterus, and the vagina proper. And that contains also contains the suspensory ligament and the mesovarium. And this shows you the various ligaments. There's the broad ligament that you can see that located right there and there that kind of hold that in place. You get the suspensory ligament as it comes down here. The blood supply of the ovaries comes to the ovarian arteries and the ovarian branch of the uterine artery. They're surrounded by a fibrous tunica albuginea, and there's two poorly defined regions, the cortex, which houses the ovarian follicles, and the medulla, which is where the large blood vessel and nerves are located. The follicle is an immature egg, an oocyte, which is surrounded by the follicle cells, which are about one layer thick, and the granulosa cells, which are more than one layer, when more than one layer is present. So we'll talk about why that's the way it says. There are several stages of development. There's the primordial follicle, which is a squamous-like follicle cells plus an oocyte. The primary follicle, which is the cuboidal or columnar follicle cells, and the oocyte. The secondary follicle, which is two or more layers of the granulosa cells, plus the oocyte. And finally, the late secondary follicle, which contains a fluid-filled space between the granulosa cell and coalesces to form a central antrum, or a holding place for the oocyte. The vesicular follicle, the Graafian follicle, is a fluid-filled antrium forms, which the follicle bulges from the ovary surface. Ovulation is the ejection of the oocyte from that ripening follicle. The corpus luteum develops from the ruptured follicle after ovulation. So after ovulation, the shell remains, and the corpus luteum is left over. And so this takes you to the process. This is really a good slide as you look at that. You start out as the corpus. You see the cortex, as well, the oocyte, the granulosa cells, the late secondary follicle. You see the oocyte here as we go through. You see the process of where the egg is corona radiata, which is another name for the ovulated oocyte. And then you see the shell, which is the developing corpus luteum, which breaks down ultimately, and the cycle begins again. And guess what? It takes about 28 days to get through that process. The female duct system includes the uterine fallopian tubes, or oviducts, and the uterus, and the vaginal vault, or as it's called, the vagina. The uterine tubes, it starts with the ampulla, which is the distal expansion of the infundibulum near the ovary, the expansion of the fallopian tubes. It's the usual site of fertilization, and it contains ciliated fibria of the infundibulum, which create currents to move the oocyte into the uterine tube. The isthmus is where the fallopian tubes are constricted and the tubes join to the uterus. The oocyte is carried along by peristalsis and ciliary action within the fallopian tube. The non-ciliated cells nourish the oocyte and the sperm and the mesosalpinx, which is the mesentery that supports the uterine tubes. This is really a process. You see the ovary right here. You get a feel for that. There's the fimbria and the infundibulum, which is the opening. There's the ampulla of the fibula, the ampulla of the fallopian tubes, and you get down here to the isthmus as it gets tighter in here, and then it opens, if you will, into the uterus proper. We talk about the uterus. The major portion is the body, and the fundus is the rounded superior portion, and the isthmus is the narrowed inferior portion, which opens in the cervix. The cervix is the narrow neck or outlet that projects actually into the vaginal vault. The cervical canal communicates with the vagina via the external os, and the uterine body via the internal os. The cervical glands secrete mucus that blocks sperm entry except during mid-cycle. The mesometrium is lateral support of a portion of the broad ligament, the lateral cervical cardinal ligaments from the cervix and superior part of the vagina, the walls of the pelvis help to support that uterus, and finally the uteral sacral ligaments secure the uterus to the sacrum. The round ligaments bind to the anterior wall. So you see the supporters include the mesometrium, the lateral cervical cardinal ligaments, the uteral sacral ligaments, and finally the round ligaments. And you get a feel for all of those as you look through this chart. The peritoneal pouches are the sacs of peritoneum that exist around the uterus. There's the vesical-uterine pouch, which is between the bladder and the uterus, and the rectouterine pouch, which is between the rectum and the uterus. There are 3 layers of the uterine wall. There's the perimetrium, which is a serous layer, which is visceral peritoneum. The myometrium, which is the smooth muscle or interlacing layers of the smooth muscle. And finally, the endometrium, which is a mucosal lining in the part that's shed during menses. The stratum functionalis, or the functional layer, changes the response to ovarian hormone cycle and is shed during menstruation. The stratum bacillus, the basal layer, forms new functionalis after menstruation and is unresponsive to ovarian hormones. The vascular supply of the uterus includes the uterine arteries, which arise from the internal iliacs, the arcuate arteries, which come from in the myometrium, the radial branches in the endometrial branch into the spiral arteries, which feed the stratum functionalis, and the stratum arteries, which feed the stratum bacillus. The spasms of the spiral arteries leads to shedding of the stratum functionalis, so it's that process which creates menses. This takes you to that process. You can see the opening of the uterus. This is what we're talking about here. You can see the epithelial layer. There's the capillaries and the uterine glands that we're talking about. There's the venous sinusoids, the lamina propria of the connective tissue, the spiral coil artery, and the straight artery that's located there. The endometrial vein and the radial arteries, you're seeing it there. And finally, arcuate artery and the uterine artery. Arcuate artery in the uterine, I'm sorry. The vagina is the birth canal and the organ of copulation. It extends between the bladder and the rectum, from the cervix to the exterior introitus. The urethra is embedded in the anterior wall of the vaginal vault. The layers of the vagina include the fibroelastic adventitia, the smooth muscle muscularis, and then the stratified squamous mucosa with rugae, and the stratified squamous mucosa really lends itself to to creating that interior layer. Mucosa near the vaginal orifice forms an incomplete partition called the hymen in the asexual or presexual female. The vaginal fornix is the upper end of the vaginal vagina surrounding the cervix. And you can see that right here. You see the mons pubis, which is the fatty area just above the symphysis pubis. You see the opening, the little skin area here, which is called the precipice of the clitoris. You can see the clitoris or clitoris. Both pronunciations are correct. See the labia majora, majora being large muscle which surrounds the opening of the vaginal vault, and the labia minora, which is the inside muscle inside the labia majora. You see the urethral opening just below the clitoris, and you see the vaginal orifice below that, and finally the anus below that. We talk about the external genitalia. We'll talk about the vulva or the pudendum. The mons pubis is that fatty area we've already shown you, overlying the pubic symphysis. The labia majora is that hair-covered fatty skin folds. And the labia minora are the skin folds that lie within those labia majora. And the vestibule is the recess between the labia minora, is that opening, if you will. The greater vestibular glands are homologous to the bulbourethral glands in the male. They release mucus in the vestibule for lubrication. The clitoris or clitoris, both pronunciations are correct, is erectile tissue which is hooded by that little hooded area called by the precipice. The glans clitoris is exposed as an exposed portion. The peritoneum is a diamond-shaped region between the pubic arch and the coccyx, and it's bordered by the ischial tuberosities laterally. And this lets you see the bulb of the vestibule, if you will. You can see the fourchette. and you can see the inferior ramus of the pubis. You see the body of the clitoris it's just below that pubic symphysis and the urethral opening. So you get a feel for what's happening deep to the tissue or deep to the introitus. In the female, the mammary glands are modified sweat glands consisting of 15 to 25 lobes. The areola is the pigmented skin that surrounds the nipple, and the suspensory ligaments, sometimes called the ligaments of Cooper, attach the breast to the underlying muscle. The lobules within the lobes contain that glandular alveoli that ultimately can produce milk post-pregnancy. Milk is produced by the lactiferous ducts, and the lactiferous sinuses open the outside at the nipple. As you can see the breast right here, you can see the skin on the outside. There's the pectoralis major muscle. There's the suspensory ligaments, so also again called the ligaments of Cooper. You see the adipose tissue, and much of the breast is really made up of adipose tissue. You can see the lobe and the areolar area of the nipple there. There's the nipple proper. There's the opening of the lactiferous ducts, lactiferous sinuses that will ultimately open there. Get a feel for what we're really talking about. Breast cancer usually arises from the epithelial cells of the ducts. The risk factors include early onset of menstruation and late menopause, no pregnancies or the first pregnancy which occurs late in life, or a family history of breast cancer. 10% are due to hereditary defects including mutations of the gene BRCA1 and BRCA2. Detection and treatment, 70% of women with breast cancers have no known risks. The early detection is via self-examination and mammography, though there's been a lot of documentation lately, especially out of Sweden, suggesting that maybe we're doing too much mammography. Treatment depends on the characteristics of the lesion. Sometimes the different kinds of cancers can be radiation, chemotherapy, and surgery, which is followed by radiation and chemotherapy. And this takes you through a mammogram, looking at that. And what we're seeing here is a normal breast, and then we're seeing a malignancy here, and it's not quite that clear most of the time because we can have cysts within the breast that look sometimes like cancer too. Oogenesis is the production of the female gametes. It begins in the fetal period. Oogonia takes the 46 chromosome ovarian stem cells and multiply by mitosis and store nutrients. The primary oocytes develop into primordial follicles, and the primary oocytes begin meiosis, but they stall in prophase 1, and we'll explain what that means. Each month after puberty, a few primary oocytes are activated. One is selected each month to resume meiosis 1. They result in 2 haploid cells, 23 chromosome cells. There's a secondary oocyte and a first polar body. The secondary oocyte arrests in metaphase 2 and is ovulated. If penetrated by sperm, the second oocyte completes meiosis 2 and goes through what's called yielding. The ovum is the functional gamete, and then the secondary polar body. So this takes you to that process. Here we go. So there's the meiotic events. There's before birth. There's the oogonium. There's the primary oocyte. If we go growth, if you will, you see the primordial follicle, secondary follicle, vesicular follicle, or Graafian follicle. There's the ovulated ovary, and finally the degenerated corpus luteum. And this takes you through that process of what happens before birth, as we talked about. The ovarian cycle is a monthly series of events associated with really the maturation of that oocyte. There are 2 consecutive phases in a 28-day cycle. There's a follicular phase, which is a period of follicle growth within the ovary that occurs in the first 1 to 14 days. There's an ovulation, which is where that egg is expelled from the ovary and is then tracks down the fallopian tube. And there's a luteal phase where the shell of that follicle breaks down and it develops in what's called the corpus luteum, and that occurs the last 2 weeks of the menstrual cycle. The follicular phase, the primordial follicle becomes primordial follicle becomes a primary follicle. Can't say that. The primordial follicle is activated, and squamous-like cells become cuboidal, and the follicle enlarges to become a primary or 1' follicle. And you can see that process we've taken you through, and these are primordial follicles. There's a primary follicle, and you can see how that has changed from that primordial follicle and to that primary follicle. You see how that has become a lot more organized. The follicular phase, the primary follicle becomes a secondary follicle. Stratified epithelium or granular cells formed around the oocyte. The granulosa cells of the oocyte guide one another's development through local management. There's a secondary follicle, becomes a late secondary follicle, and a connective tissue called theca folliculi and granulosa cells cooperate to produce the estrogens. And so follicles actually produce estrogens in the ovary. The zona pellucidea forms around the oocyte, and the fluid begins to accumulate. And you can see that there's the zona pellucidea, and develops the antrum, and so it develops kind of a little pool of fluid inside, and which creates this little antrum, or this little opening within the follicle proper. And you get a feel for that late secondary follicle right there. The late secondary follicle becomes a vesicular follicle. The antrum forms and expands to isolate the oocyte from its corona radiata on the stalk. The vesicular follicle bulges from the external surface of the ovary, and the primary oocyte completes meiosis I. The ovary wall ruptures and then expels that secondary oocyte with its corona radiata, and that creates what's called Mittelschmerz pain. That's a twinge of pain that some women feel during ovulation. Mittelschmerz was a German doctor who documented that pain. 1 to 2% of ovulations release more than just one secondary oocyte, which if fertilized results in those fraternal twins that we see. And this takes you to that process as a mature vesical follicle, which is carried out. Meiosis I is ready to be ovulated. You can see that large antrum located right there. And you see where that follicle ruptures and expels the contents out of the abdomen to be picked up hopefully by the fimbria of the fallopian tube. The luteal phase is where the ruptured follicle collapses on itself, and the ovary closes, and the granulosa cells and internal thecal cells form what will be called the corpus luteum, or the remaining shell of that follicle. The corpus luteum actually secretes the progesterone, primarily. A small amount of estrogen, but a large amount of progesterone. If there's no pregnancy, the corpus luteum generates into corpus albicans in about 10 days. If pregnancy occurs, the corpus luteum produces hormones until the placenta takes over at about 3 months. So the corpus luteum produces the hormones until that placenta starts producing its own hormones, becomes the primary source of both the estrogen and the progesterone during pregnancy. Again, there's the corpus luteum, forms that ruptured follicle. Establishing the ovarian cycle during childhood, ovaries grow and secrete small amounts of estrogens that inhibit the hypothalamic release of GnRH. As puberty nears, GnRH is released. Follicle-stimulating hormone and luteinizing hormone are released by the pituitary and act on the ovaries. And these events continue until the adult cyclic pattern is achieved and menarche, or the cessation, the stopping of menses, periods, occurs. During childhood until puberty, the ovaries secrete very small amounts of estrogen, and estrogen inhibits the release of GnRH. At puberty, leptin from adipose tissue decreases estrogen inhibition. GnRH, FSH, and LH are released, and in about 4 years, an adult cyclic pattern is achieved, and menarche occurs. So that takes you through that process where menarche being the beginning of menses. Menopause would be the end of that. Hormonal interactions during a 28-day ovarian cycle. Day 1, GnR is released, causes GnR from the hypothalamus, causes the release of FSH and LH for the anterior pituitary. FSH and LH cause a growth of several follicles and estrogen release, or increased estrogen levels. It inhibits the release of FSH and LH ultimately, stimulates synthesis and storage of FSH and LH, and enhances further estrogen output. Estrogen output by the vesicular follicle increases, and high estrogen levels have a positive feedback effect on the pituitary at mid-cycle, and there's a sudden luteinizing hormone surge at day 14. The effects of the LH surge causes the completion of meiosis 1. The secondary oocytes continues to metaphase 2, triggers ovulation, and transforms the ruptured follicle into the corpus luteum. The corpus luteum produces inhibin, progesterone, and a little bit of estrogen, and these hormones inhibit FSH and LH, and declining LH and FSH into the luteal activity and inhibits that follicle development. Days 26 and 20 through 28, the corpus luteum generates, and the ovarian hormone develops, hormone levels drop sharply, ends the blockade of the FSH and LH, and the cycle begins anew. And this takes you through that same process we just walked through. We're talking about how that occurs. Fluctuation in gonadotropin levels. You see the fluctuation levels of LH and FSH through the follicular phase and the follicular phase as well as the luteinizing phase. You see the ovarian cycle. There's the follicular phase, the primary follicle turns to the secondary follicle. The secondary follicle, day 14, ovulation occurs, maybe some middle shortness pain here. There's the shell that remains, develops corpus luteum, starts to degenerate down, and produces progesterone. The menstrual cycle is really a cyclic changes in the endometrium, that inside layer of the uterus, in response to the ovarian hormones. There are 3 phases. Days 1 through 5 is menstrual phase. Day 6 to 14 is the proliferation phase, which is pre-ovulatory. And the days 15 to 28 was the secretory phase, which is post-ovulatory. And it's the phase which is constantly a 14-day length. Menstrual phase, the ovarian hormones are at their lowest. Gonadotropins are beginning to rise. And the stratum functionalis is shed, and the menstrual flow occurs. The proliferation phase, where estrogen levels prompt generation of a new functional layer, increased synthesis of progesterone receptors in endometrium, and the glands enlarge, the spiral arteries increase in number in the endometrium. The secretory phase is where the progesterone levels prompt the further development of endometrium. Glandular secretion of glycogen, preparing the endometrium for potential implantation of a fertilized egg and formation of a cervical mucus plug. And you see that fluctuations of estrogen and progesterone in the hormone level. You see that in the beginning phase, high estrogens, which because they're secreted by the follicle, see high progesterones as they're secreted by the corpus luteum. You can see the phases we go through. There's the menstrual phase for the loss of endometrium. The proliferation phase is develops thickness of the endometrium. You see the secretory phase where it starts to secrete mucus and other nutrients onto the surface of the endometrium and takes you to that process. The uterine cycle of fertilization does not occur. The corpus luteum degenerates, progesterone levels fall, the spiral arteries kink and spasm, and the endometrial cells begin to die. The spiral arteries constrict again, they relax and open wide, and that rush of blood fragments the weakened capillary beds, and the functional layer, that endometrium, is sloughed off. Promotes oogenesis and follicle growth in the ovary. That's what estrogens do. And they exert an anabolic effect on the female reproductive tract, or the buildup of macromolecules. They support the rapid but short-lived growth spurt at puberty. Estrogen-induced secondary sex characteristics include the growth of breasts, increased positive subcutaneous fat in the hips and breasts, and the widening and lightening of the pelvis. The metabolic effects, they maintain low blood cholesterol and high HDL levels, and they facilitate calcium uptake. The effects of progesterone is progesterone works with estrogen to establish and regulate the uterine cycle. The effects of placental progesterone during pregnancy inhibit uterine motility, helps prepare the breast for lactation. Female sexual response is initiated by touch and psychological stimuli. The clitoris, vaginal mucosa, and breasts are becoming gorged with blood. The vestibular gland secretes and lubricates the vestibule. Orgasm is accomplished by muscular tension, increase in the pulse rate and blood pressure, and rhythmic contractions of the uterus. The females do not have a refractory period after orgasm and can experience multiple orgasms in a single sexual experience. Orgasm is not actually essential for conception. We talk about other things like sexually transmitted diseases. They're also called STDs, also called STIs. Or sexually transmitted infections, or venereal diseases, VDs. They're the single most important cause of reproductive disorders, or non-fertility in males and females. The first was gonorrhea, caused by the bacteria Neisseria gonorrhea. It's a bacterial infection of the mucosa of the reproductive and urinary tracts. It spreads by contact with an infected person via genitalia, anal, and pharyngeal mucosa. Its signs and symptoms in male develop urethritis, they have very painful urination, and a discharge of a very nasty pus. Females, 20% actually just can display no symptoms. They can have abdominal discomfort, vaginal discharge, or abnormal uterine bleeding, which could result in pelvic inflammatory disease and sterility. Treatment is with antibiotics, but there are many resistant strains, and they're becoming far more prevalent, and that kind of occurred post-Vietnam. Strangely enough, a lot of military men came back with a antibiotic-resistant gonorrhea. Syphilis is caused by the bacteria Treponema pallidum. It's a bacterial infection transmitted sexually or contracted congenitally from mother to baby. Infected fetuses are stillborn. They die shortly after birth. Infection is asymptomatic for about 2 to 3 weeks. A painless chancre, which is kind of a lesion, appears at the site of infection and then disappears in about 2 weeks. If untreated, the secondary signs appear several weeks later, at about 3 to 12 weeks, and then disappear, and that can be a pink rash, which can be on the palms and the soles of the feet. It causes fever and joint pain, and the latent period may or may not progress to tertiary syphilis, which is characterized by gumas or lesions of the brain, the central nervous system, blood vessels, blood, and skin, and the treatment is penicillin. Chlamydia is the most common bacterial STI or STD in the United States, and it travels very nicely with gonorrhea. It's responsible for 20 to 50% of all diagnosed cases of pelvic inflammatory disease today. The symptoms are urethritis, penile vaginal discharge, abdominal, rectal, and testicular pain, painful intercourse, and irregular menses. It can cause arthritis and urinary tract infections in men and sterility in women, and the treatment is tetracycline or a derivative like doxycycline. Viral infections include genital warts. Genital warts are caused by human papillomaviruses, HPV. It's the second most common STD or STI in the United States. And there's increased risks of cancers in the affected body regions. And in women, it causes a cancer of the uterus, which is called cancer in situ. There's actually a vaccine out now, which is called Gardasil, which will prevent the infection of HPV in females, and it has to be given before their first sexual contact. Genital herpes is caused by human virus type 2. Those are type 1, which tends to be more oral. Type 2 tends to be more genital, but with the change in sexual habits, type 1 and type 2 are intermingled between oral and genital. It is characterized by latent periods and flare-ups. Congenital herpes can cause malformations of fetus, and the treatment is acyclovir and other antiviral drugs which treat the outbreaks but do not treat the latent infection proper. All right, so we've talked about this is chapter 26, which is the reproductive system. Thank you very much.